All right, so gold standards for COPD exacerbation by me, Nick Riesenberg. This will be the first video of four talking about COPD and different aspects of it and diagnosis. What is COPD? Well, it's a chronic obstructive pulmonary disease. It's an inflammatory obstructive disease characterized by chronic respiratory symptoms such as dyspnea, shortness of breath, cough, sputum production, wheezing, and exacerbation due to abnormalities of the airways. These abnormalities cause persistent, often progressive obstruction to airflow, and this is due to the tightening of the airways, the constriction. COPD is one of the top three causes of death worldwide. 90% of these deaths occur in low and middle income countries. More than 3 million people died of COPD in 2012, accounting for 6% of all deaths globally. So as you can see, COPD is a big issue and it affects a lot of people, not only in the USA, but the whole world wide. So common causes for COPD, they can result from genetics or environmental exposures over time or a combination of both. And environmental exposures consist of tobacco smoke inhalation, toxic particles or gas inhalations. These can be found in the household or outdoor air pollution. So just toxic fumes. You know, if you have a workplace that you work with, there's a lot of toxic fumes that could also be a contributor. Factors that can contribute from the host genetics could be accelerated lung aging, abnormal lung development, and these can also be environmental factors as well as from exposures that cause this, but it can be from genetics in general as well. So the diagnosis of COPD. So first thing you want to look at signs and symptoms. You should determine if they're presenting with any of the signs or symptoms to start to even begin to think that maybe COPD is a factor that they're dealing with. Three cardinal symptoms of COPD are chronic dyspnea, so shortness of breath, and that's the most characteristic symptom of COPD. Chronic cough, it's present up to 30% of COPD patients. It's often the first symptom of COPD and can be frequently discounted by the patient as an expected consequences of either them if they're someone who has a smoking history, they smoke, or if they've had those environmental or workplace exposures, they're going to kind of displace that cough thinking, well, that's a natural occurring thing, which it very well could be from that, but it could be something caused on by those environmental exposures or the smoking. And then sputum production, which is present in up to 30% of COPD patients. So other signs and symptoms other than the cardinal three, chest tightness, because you got to think of the constriction of the airways, wheezing, also the constriction of the airways, fatigue, because you're not getting a proper ventilation, which is not going to give you proper oxygenation, weight loss, muscle mass loss, anorexia, all those kind of coexist there together, can be happening. History of exposure to risk factors, and then the history of the recurrent respiratory infections. So the diagnosis of COPD, here are methods and tests that are used otherwise than just the symptoms themselves. So you have spirometry, post-bronchodilator test, and that goes in conjunction with the spirometry. Modified MRC dyspnea scale, again, dyspnea is a shortness of breath, and the CAT assessment, which I'm going to talk about each one of those individually here in a moment. So first off with spirometry, simple tests used to diagnose and monitor certain lung conditions by measuring how much air you can breathe out in one forced breath. So spirometry is the most reproducible and objective measurement of airflow obstruction, which is, with the constriction, that's the biggest part with the COPD is their airflow is being obstructed. They're being able to get air in, but they're not being able to get it out. Some of the benefits of spirometry is that it's not invasive, it's very cheap, it's reproducible and possible in pretty much any healthcare setting. To perform spirometry, the patient must perform a forced vital capacity maneuver, or FVC for short. FVC is the volume that can be expired as forcefully and as rapidly as possible after a maximum inspiration. So that would be an example of a forced vital capacity maneuver without it being, measured. So the four volumes that can be measured during that forced vital capacity are the forced expiratory volume in 1 second. Short is the FEV1. So that's in the first second, how much of that expiratory volume are you exhaling? Forced expiratory flow 200 to 1200, or FEV 200 to 1200. Forced expiratory flow from 25 to 75, FEV 25 75. Peak expiratory flow rate, PEFR. So I didn't go much into those other ones because they're not really as pertinent for COPD, but those are values that you get from that forced vital capacity maneuver. So the most important values, as I was saying, is pertaining to diagnosing and obstructing lymph disease such as COPD, are the force vital capacity itself, the value you get from that, and the FEV1. And one reason for that is because you take the FVC and the FEV1, and they're used in conjunction to determine the FVC slash FE1 ratio, which is the best indicator for an obstructive disease. So the FEV1, volume of gas expiring the first second of the vital capacity maneuver, is a good obstructive airway, a good indicator. You can get a good assessment of that, but the overall best one is that FEV percent, which is that FEVC slash FEV1 ratio. And the values for those, you do the FEV1 times FVC times 100, and that will give you the FEV1 percentage. So if you get a FEV FEV percent or a FEV1 slash forced vital capacity ratio of less than 0.7 or 70%, because that's how you get that 70% with that times 100. That's going to be indicative of an obstructive airway disease. So that's a key factor that you're looking for there is, are they getting a ratio higher than 70% or lower than 70%? So classification of airway or airflow limitation severity. So these are kind of different classifications of how progressed that COPD is right now. So goal 1 would be mild, and that's when you get the FEV1 greater or less than 80% of the predicted. And then goal 2 would be moderate, that's 50% or up to that 80%, so 79%. So 50% to 89% is going to be a moderate airflow limitation. And then goal 3, which is severe, is going to be between 30% and 50% of the predicted. And the predicted is what they're, how you get that value is by their ideal body weight. You predict what they should be able to do, and then you go ahead and do the spirometry, and it'll give you what they're actually able to do at this point in time. And then goal 4, which is very severe, is going to be if it's less than that 30% of predicted. So post-bronchodilator. That's used in conjunction with the spirometry. Spirometry is first used to get that accurate measurement and assessment of the performer's lung condition prior to receiving any medication, that bronchodilator. So we just want to get a good look at how they are able to breathe on their own. What are the values that they're getting on their own without the help of any medication? And after that, first spirometry, the measurements are obtained, and then a bronchodilator is going to be given. Usually, I think it's 2 minutes after the fact of their first one. They're going to give that bronchodilator, then wait 2 minutes before they perform spirometry, give that time to go into effect. And they repeat the spirometry, and then it determines the lung performer's condition degree of airway reversibility when given a bronchodilator. So these 2 tests are mandatory to establish a diagnosis of COPD. So you do your spirometry, you get your values, then you take a bronchodilator, you wait 2 minutes, and then what we're looking for is this bronchodilator helping? Is it giving less constriction or some relief of those airways and giving some bronchodilation effects to help you overcome those airway obstructions and restrictions? So to establish if the obstructive pattern is reversible, there must be a 12% or a 200 ml increase in the FEV1. So if your FEV1 was, 0.5, we're looking for it to increase by 12% when we give you that bronchodilator to say, like, okay, this is an effective medication to give this patient. We are seeing a good increase of reversibility. This will benefit them during an exacerbation and daily practice as well. So another one that I mentioned earlier was the modified MRC dyspnea scale. This was the first questionnaire developed to measure breathlessness, which is a key symptom in many patients with COPD. Like I said, it's a cardinal symptom. So MRC, the Modified Medical Research Council, and this is the dyspnea scale. So this is something that the provider or us as an our team may just ask them to see which grade they're at, or have them look at it and say, well, where do you fall in? So grade 0, no breathlessness except with strenuous exercise. So that's where we want to be. That's normal. I'm never out of breath unless I'm running from a bear. I'm running on the treadmill. I'm doing something strenuous. That's when I start to have out of breath symptoms. One is breathlessness when hurrying on the level or walking up a slight hill. So like I'm in a fast-paced walk, I'm trying to get somewhere, or I'm going up a slight hill and I can feel myself get a little out of breath. And then two on that scale would be I'll walk slower than contemporaries on level ground because of breathlessness, or it has to stop for breath when walking at own pace. So this is basically, I'm out of breath just doing kind of normal activities for the most part. I'm just walking. I move slower than most people because I'm already out of breath. And then grade three, you stop for breath after walking about 100 meters or after a few minutes on level ground. So this is a little bit more progressive. Not only am I moving slower and I'm having a hard time, I have to actually take a break. This is not a strenuous exercise. This is, normal day-to-day activity that we all do is just walking around and going to the grocery store, walking your dog. So they're having to take a breath, stop and catch their breath every 100 meters or so. Four, which is the worst stage or the most progressed stage, is too breathlessness to leave the house or breathless when dressing or undressing. So that's even further into that everyday activity that is being impended on of my breathlessness. I have a hard time getting out of bed, brushing my teeth, putting on my clothes, going to the restroom. It's all those daily activities. I'm don't even leave the house because of how out of breath I am, because it's an issue. So the CAT assessment, which was the fourth procedure or test, diagnostic test that I had in that list, is an 8-item questionnaire that assesses health status in patients with COPD. Score ranges from 0 to 40. So over or equal to 25 is the threshold for considering treatment. So you ask them these questions or have them fill out that questionnaire, would probably be the best way. And so they indicate it by 0 is none, 5 to most. So I never cough. 0, 1, 2, 3, 4, 5. Coughing is a cardinal symptom of COPD. They're going to put in the box like how often do they feel like they cough. I have phlegm, mucus, again, sputum, a cardinal symptom. My chest does not feel tight at all. Chest tightness is not a cardinal symptom, but it is a symptom. When I walk up the hill or fly stairs, I am not breathlessness. How further do you agree with that? 0 out of 5 or 5 out of 5? I agree. I don't have breathlessness. Am I limited doing any activities at home? And those tie into the dyspnea because that is a cardinal symptom and the biggest symptom. Am I confident in leaving my home despite lung conditions? Sleep soundly, have lots of energy. These are all just confined to the questions 0 through 5. Cough all the time. My chest is completely full of phlegm. My chest feels very tight. So that I kind of got off base there. But so on one side, we have I never cough, 0. That's the scale. And then on the other side, I cough all the time. So if you feel like you cough all the time, you're going to go to that 5 stage. And then when my chest does not feel tight at all, and then on the opposite side, it says my chest feels very tight, 0 to 5. Like, where do you fall into that is what it's looking for. So if you count up all these options here, it goes 5, 10, 15, 20, 25, 30, 40. If they score over 25 on that, then we might need to consider some treatment for them because they are definitely having some issues that may be COPD related. But in conjunction with all those tests, you can get a very firm picture of where this patient is living and how you need to maybe address them in their current state. Thank you.